Let's discuss about SGLT2 inhibitors. The FDA approved indications are type 2 diabetes mellitus for glycemic control adjunct to diet, exercise, and metformin, heart failure in NYHA class 2 to 4 across all left ventricular ejection fraction categories, including preserved, reduced, and impaired ejection fraction. In the CKD, they prevent the progression of the disease and the reduction of major adverse cardiovascular event in patients with diabetes mellitus and established cardiovascular disease. Off-label use includes obesity along with the GLP-1 receptor agonist, non-alcoholic fatty liver disease, adjunct therapy in type 2 diabetes mellitus with NAFLD. These are the FDA-approved drugs and doses in respective categories. We need to assess the KFT before initiation and they are contraindicated if EGFR less than 30 or 45 for glycemic control and EGFR less than 20 for heart failure and CKD patients. They are also contraindicated in patients with immunocompromised kidney transplant patients. Other contraindications include pregnancy, breastfeeding, severe hepatic impairment, patients on dialysis, and hypersensitivity to the drug. Mechanism of action of SGLT2 inhibitors. Primary action is inhibit SGLT2 protein in the proximal convoluted tubule, thereby reducing glucose and sodium reabsorption and promoting urinary glucose excretion. Cardioprotective effects include increasing distal tubular sodium load, thereby inhibiting RAS, and reduce the afterload and preload. Vasodilation can help. They stabilize the cell membrane potential, thereby reducing the arrhythmias. Nephroprotective effects include reduces intraglomerular pressure, decreases albuminuria, and they reduce the kidney hypoxia, inflammation, and fibrosis. Adverse effects include UTI, urosepsis, and pyelonephritis because glucosuria promotes the bacterial growth. Genital mycotic infections are more common in females. DKA and euglycemic DKA have 3 to 7-fold increased risk. We need to correct the volume depletion before starting the therapy, and these drugs to be withheld before surgery or prolonged fasting or critical illness to reduce the risk of ketoacidosis. AKI is more common with hypovolemia, diuretic use, elderly patients, and renal impairment. Hyperkalemia is more common with ACE inhibitors, ARV use, or in patients with renal impairment. Hypoglycemia is common with the concomitant use of sulfonylureas and insulin. Lower limb amputation has more chances in patients of peripheral vascular disease, neuropathy, history of diabetic foot ulcer, or amputation. Other adverse effects include Fournier's gangrene, hypersensitivity reactions, bone fractures, bladder cancer, and dyslipidemia.